It's sort of our bread and butter in the ICU, managing patients with acute respiratory failure, and specifically those with acute lung injury and ARDS. And we've divided this into two parts. I'll do them back to back. But the first part, we're going to focus on the pathophysiology and what this looks like. So that's ARDS. I think everybody in the room recognizes it. It's a diffuse injury to the alveolar capillary interface. By definition, it's bilateral. And it leads me to my first question. ARDS is defined by clinical criteria. Which of the following clinical parameters is not part of the American European definition of ARDS? The P-DEF ratio on 5 centimeters of PEEP, bilateral infiltrates, absence of left atrial hypertension, acute onset. What is not included in the consensus definition of ARDS? And the correct answer is indeed A. You have to have a P to F ratio, a PO2 to FiO2 ratio of less than 300 to be considered to have acute lung injury criteria or meet acute lung injury criteria, or less than 200 to meet ARDS, the acute respiratory distress syndrome criteria. But these are on any level of PEEP. And that's one of the criticisms of this particular definition, is that somebody on 0 of PEEP might have ARDS, and you give them 5 of PEEP and it all goes away. And they don't have ARDS anymore. And that is an issue. It is an issue. This definition was adopted, however, without a PEEP requirement to make it more universally applicable to clinical trials around the world. And as I say, it is a flaw in this particular definition. Some other flaws is this bilateral infiltrates. One man's infiltrate is another man's atelectasis, is another man's pulmonary edema from cardiogenic causes. And this causes a lot of issues in defining this syndrome. And another thing about this definition is, I think everybody in the room will agree with, it's pretty doggone nonspecific. And again, another problem with dealing with this thing we call ARDS, because these criteria here can apply to a whole bunch of different disease problems inside the lung, as we'll touch on in a minute. So, P-DEF ratio on 5 centimeters of PEEP is the incorrect answer. The P-DEF ratio is important, but it's on any level of PEEP that the patient happens to be on. So, as I say, the American European consensus definition, appropriate clinical setting, these are the P-DEF criteria, bilateral infiltrates, and no evidence of LA hypertension. The PEEP is not specific. This is a problem. The chest criteria are very vague. And again, as I mentioned, there are no mechanistic considerations here or disease pathophysiology considerations. And these are huge problems. These are huge problems that make it difficult to understand the literature in ARDS. This is probably a better way of characterizing the lung injury. It's not used a lot, at least in the official definitions, but I think it's a useful score that categorizes ARDS based upon PEEP requirements, hypoxemia, the chest X-ray, and lung compliance, and then you can add up. And actually, I think this is probably a better way of doing it, but the American European Consensus Group has not chosen to do this. So, ARDS occurs quite a bit. These numbers right here give you an idea. We're talking about several 100,000 patients each year in the United States come down with either acute lung injury or the more serious form, acute respiratory distress syndrome. And it accounts for tens of thousands of deaths in the United States every year. So it's an important disease, and as I said at the very beginning, it's kind of our bread and butter in the intensive care unit. So how does ARDS sort of work? There's a trigger. Something triggers this process. And this trigger, as I'll mention in a moment, can either directly injure the alveolar capillary interface, a classic example, of course, would be an aspiration, or this trigger works more indirectly through perhaps systemic inflammatory processes that hit the lung as it does many other organ systems. Systemic inflammation that hits the brain, the heart, the kidneys, the adrenal glands, etc., also hit the lungs and produce an alveolar capillary injury. And then confusing this issue, of course, is that this alveolar capillary injury can feed back and produce various inflammatory mediators that can go outside the lung and cause systemic inflammation elsewhere in the body. So, again, a direct injury, an indirect injury, and then potentiation of systemic inflammation as a consequence of this lung injury. This can be made worse by complications, and as I get into my second presentation with you, we'll talk more about these iatrogenic problems that develop. And the syndrome, as you all know, it's a permeability edema. So in other words, the capillaries leak. Surfactant exists in the lung. It's not a surfactant depletion syndrome, but the surfactant doesn't work. It's broken down. There are capillary thrombi that occur. These produce stiff lungs, muscle fatigue, shunts, hypoxemia, and if bad enough, even pulmonary hypertension. So let's talk about the triggers. This slide is in your handout. It's a little out of place there. As I said, there's a primary and there's a secondary, a direct or an indirect form of pathophysiology. Or the direct, as I say, the classic example is aspiration, direct lung infection, lung contusions, inhalation injuries. These diseases actually tend to be a little more patchy and perhaps less PEEP responsive, although that's controversial. It can evolve, as I said, the lung inflammation can produce inflammatory cytokines that can create a systemic inflammatory response. If it does not do that, the outcome is generally better than if the ARDS is part of a systemic inflammatory process. So here the lung is one of many organs involved, and classic examples, of course, are sepsis, pancreatitis, and severe hypotension from any cause. This is generally a more diffuse process, and it is sometimes thought to be more PEEP responsive. The outcome, as I say, is worse than primary. So this is how often you'll see ARDS. So these are patients with sepsis. Sepsis alone will produce ARDS about 30 or 40% of the time. If it's in conjunction with these other risk factors, maybe as many as 2/3 of these patients will develop ARDS. And aspiration by itself produces ARDS maybe 10% of the time. In conjunction with other things, that risk goes up. And overdoses, I can't read it from here. But other processes that can cause lung injury. These are kind of rough estimates as to how often these triggers will actually produce acute lung injury and ARDS. And again, the open bars are that risk factor alone. The closed bars are those risk factors in conjunction with other risk factors. So again, we start with a trigger, and we produce either a direct injury or an indirect injury. I missed a slide here. Okay, sorry. These are some of the chemical and cellular mediators involved in this process. I'm not going to go through them. There are a whole list of them, and the list grows longer each day. I can't believe I lost a couple of slides there. I don't know where they went. In any case, this goes on, as I say, to produce this syndrome characterized by permeability edema and the like. So here's some work. It's a nice review by my good friend Claude Pianadosi back home. This is a nice curve that depicts the concept of permeability edema. So this is looking at lung water, and this is looking at left atrial pressure right here. And you and I will not develop lung water until we get our left atrial pressures quite high. But in this syndrome, with this acute capillary injury, you get a much earlier development of lung edema. This is the so-called non-cardiogenic or permeability edema. So there's ARDS versus you and I. The stiff lungs are best described by pressure-volume curves, pressure over volume. You and I here in the room, we have a fairly steep curve and can generate a fairly high volume without at modest levels of pressure. As you get ARDS, this curve becomes flatter, and more severe ARDS, it becomes flatter still. So this is the classical mechanical changes that you will see in a patient with acute lung injury. Now there's this notion of recruitable versus non-recruitable lung in ARDS. And up here on the top is an idea of a patient who's got a bilateral injury, but it's pretty patchy, and there's not a whole lot of lung there to recruit. So this is a low recruitable lung. Down here, however, the injury is more diffuse in both lung fields, and this lung does respond to PEEP. And there's been a lot made of this recruitable versus non-recruitable lung, and it appears that the more recruitable your lung, the higher your mortality. I think this is a little misleading because more recruitable lung usually means you have more lung that's injured. And so I'm not so sure this curve doesn't really reflect the extent of the inflammation in the lung as opposed to the whether or not it is recruitable. But again, these data are out there, and people talk about recruitable versus non-recruitable lung as a predictor of mortality. ARDS moves through various stages. So at the beginning, at the initiation, the X-ray may actually look fairly normal first few hours. If you were to do pathology on it, you would find a lot of neutrophils. Over the next couple of days, the X-ray starts to develop abnormalities in it. Again, neutrophils are the major cell type. You'll see edema, and you'll see type 1 cell. Now, type 1 cells, you'll remember, are the lining cells of the alveolus that participate in the gas exchange processes of the lung. Over the next week or so, the X-ray may become more diffuse. Now the fluid in the lung is becoming more exudative, and you'll see the type 2 cells, the surfactant and repair cells, starting to proliferate. And over the next several weeks, if it lasts that long, lymphocytes enter the lung and fibrosis starts to develop. And I want you to focus on this lymphocyte here because that's the rationale behind using late-stage steroids. And I'll talk about that in my second presentation when we talk about management. So lymphocytes, are the cell type that comes in later and participates in the healing and the fibrosis process. Steroids are not particularly susceptible to steroid therapy, or neutrophils are not particularly susceptible to steroid therapy. So Wes touched on some of these ideas yesterday. I'll give you my take on it. Outcome in ARDS has gradually improved over the last 2 decades, changed little until the last few years, gradually worsened over the last decade, not changed since first described in 1967. So how are we doing in taking care of this process? Yeah, I would agree with the majority here. I think it has gradually improved over the last couple of decades. There's been some discussion as to whether this has been a steady improvement or whether we may have stalled recently. As I say, I'll give you my take on this. So this is data that's been around for a few years. The one I'd really like is this University of Washington study, because it was done exactly the same way in 1983 and 10 years later in 1993. So same methodology, same hospitals, same investigators, same everything, and a rather substantial improvement in mortality from ARDS using very, very similar methodologies that I think support strongly that since Ashbaugh-Petty first described this syndrome back in the late 60s, we've been doing a better job. In 1994, the large ExoSurf trial reported 40% mortality, and the ARDSNet trial in 1999, and then the subsequent alveoli trial in 2003. I think we are gradually getting better. As I mentioned earlier, clearly one of the most important predictors of mortality is whether or not this is a systemic process or not. If it can stay just in the lung, your mortality is considerably better than if the lung is part of a systemic process. Now, the studies Wes mentioned yesterday, or the one he focused on, was the FUA trial published just a year ago, that summarized 89 studies. Many of them were observational, but a good hunk of them were randomized controlled trial. And Wes showed you these data yesterday that sort of suggested that since about the mid-90s, we've been kind of flat here. And this takes us out to around 2005. And it's raised the issue of whether or not we've sort of stalled in our improvements in managing ARDS. Laurent Brochard wrote a nice editorial here challenging that conclusion. He said these studies were widely or had a lot of patient heterogeneity. Definitions varied. The consensus definition was not even in use until 1994. And this is the part I thought was the most interesting. He said the fact that it's flat, even if it is flat, is actually probably a good sign, because we are treating clearly sicker patients, more patients with more sepsis, more immunosuppression, older populations, more aggressive surgeries, and the like. And Laurent Brochard's conclusion was that, in fact, we are continuing to make important strides. Another study, the Erickson trial, looked at just ARDS mortality. This is pre-ARDS network. This is looking right at the first study and noticing that even in the ARDS network, using the same investigators and similar definitions and the like, mortality does seem to be getting better. So my take on this is I do think ARDS is getting better. My second presentation will talk about management, and I think those management strategies are paying off. So long-term mortality, that is, if patients do survive, this is an area Wes also touched on yesterday. You're not home free if you get out of the ICU having survived ARDS. There still is an 11% mortality rate in the first year. That's not usually due to respiratory problems, but usually due to the comorbidities that produce the ARDS in the first place. At 1 year, there still are functional changes in these patients. The vital capacities come back up pretty well, but the 6-minute walk test is still low. There are important psychosocial issues measured by the SF-36. There is this PTSD-like syndrome. Wes touched on a number of these things yesterday. We're not sure why these neurocognitive effects last so long. Is it the hypoxemia? Is it the hypotension? Is it the drugs that we gave them? And no one's really quite sure. But unfortunately, the bottom line is, even if we get them through ARDS and out of the hospital, there are some important issues. So let me sort of summarize this very brief introduction. ARDS is a syndrome. It's a syndrome of an alveolar capillary injury. Things that hurt the alveolar capillary interface. And again, direct triggers, direct insults to the capillary membrane, or systemic disease. And this important concept that I'll come back to in my second presentation of alveolar capillary injury producing cytokines that actually can cause systemic inflammation elsewhere. The syndrome is made worse by mismanagement, and these are the classical clinical presentations that you will see. So I want to stop my first presentation here.